All right, so we'll go ahead and get started. Thank you for joining us today. My name is Kimberly Buckingham, and I am from Children's Hospital New Orleans. I will be moderating our town hall today. But this is the Return to School Support Town Hall from Children's Hospital New Orleans. We are facilitating this in collaboration with the Louisiana Department of Education, and this is our first of several town halls that we will be offering as a supplemental resource to the LDOE's reopening recommendations. So what I will do is just go ahead and get started with a quick introduction. For those of you that are not familiar with Children's Hospital New Orleans, we are a pediatric, solely focused, freestanding hospital. Our main campus is located here in Uptown New Orleans. And the image that we have on the screen is our soon-to-be completed main campus. We just embarked on a $300 million expansion project and have been reinvesting that back into the community in several ways. We also have locations across the rest of the greater New Orleans area, as well as throughout the state. We have over 400 pediatric specialists on our team that are focused on developing best practices for kids. So throughout the COVID-19 pandemic here in Louisiana, we have been collaborating with other healthcare institutions and other hotspot communities across the nation to develop pediatric best practices. So as you can imagine, we're very excited when the Louisiana Department of Education selected us as their statewide partner to offer medical guidance on these guidelines for implementing CDC recommendations and guidelines in schools. Just a little bit of overview on what to expect during these town halls. I will be the moderator. What I will do is I'll kick off each town hall and I will collect questions from all participants that are muted through the chat feature. Through that feature, please just submit your questions to the all panelists option, and I will make sure to communicate those questions verbally to our speakers. Our speakers will provide a quick update on COVID-19 in Louisiana from a pediatric perspective. We'll cover frequently asked questions that we have received from several of our educational partners as well as patients. And then we'll just open up the rest of the town hall to answering questions. Just to keep in mind, this town hall series will continue through the end of August. We'll be doing this on a 2-week basis. So every Tuesday afternoon from 1 to 2 p.m. beginning today, we'll be offering an opportunity to run through frequently asked questions and respond to any new questions. Additional resources to review questions include us, Children's Hospital New Orleans, through our hotline, and your regional medical directors. The difference between these two resources really comes down to what type of questions are coming from you as schools. So I will emphasize that the Children's Hospital New Orleans hotline is for medical questions relating to a specific student or individual. That hotline is available weekdays from 7 a.m. to 11 p.m. and weekends from 8 a.m. to 8 p.m. All other operational questions beyond medical inquiry about an individual would be most appropriate to review with your regional medical director through school leadership. So if you have any other questions about that, please let us know. We can provide clarification. Just a quick introduction on our speakers for today. We do have Ken Bradford from the Department of Education. As many of you might be aware, he is the Assistant Superintendent for College and Career Readiness. He's been a longtime Louisiana educator and has spent over 20 years at the Louisiana Department of Education. Ken, do you want to make any introductory comments before we kick it off to Dr. Finger?
Yeah, I will take a moment to make a couple of comments. First, we'd like to thank Children's Hospital for being such a great partner as we have rolled out these town hall series. And I just, while everyone's on, just provide a quick update. We worked through much of May and into June to establish a set of school reopening guidelines, our Strong Start 2020 school reopening guidelines and resources. We released those on June 25th to the field. We've provided webinars and informational sessions on those. that guidance document that we released. Also coming out of the legislative session was an ask for our state board to meet no later than July 15th and adopt what would be minimum requirements for school systems. So they are tentatively working on establishing a date for the state board to meet prior to July 15th to adopt certain parts of the guidelines now as requirements. And I think for anybody that has looked at those, if you looked at page 5, there's a table in our reopening guidelines. I'll actually put those in a chat in a little bit, the guidelines. But those are the things that you would see will be probably be being recommended as requirements. And those are the things around transportations and symptom monitoring with temperature checks upon arrival, etc. So that's where we are on the guidelines and the requirements for reopening. Again, we look forward to continuing to work with Children's Hospital throughout the summer on these town hall meetings, and just really want to encourage the field and the people participating to ask questions of our medical professionals while they are here. They are the medical professionals, much more so than myself, and so they can answer your medical questions today. So please take full advantage of it, and thank you.
Thank you, Ken. We also are very grateful for the partnership and appreciate the opportunity to help in the way that we are. I'll next introduce our main speaker for the town hall, and this is Dr. Leron Finger. Dr. Finger is our Chief Quality Officer here at Children's Hospital New Orleans. He is a pediatric intensivist by training, and he has really been the main physician lead alongside with our infectious disease specialist team of our CHNOLA COVID-19 Command Center. He, on a normal basis outside of the pandemic, oversees the patient and team member safety and quality efforts, and also leads a team of infection prevention specialists. So I'll go ahead and kick this off to Dr. Finger as he goes through commonly asked questions, and we'll open it up for additional questions. And I will emphasize that this guidance is really intended for all educators across the educational institution spectrum. So whether you're from a public, private, charter school, or early learning center, this is information that Dr. Finger will be happy to run through. Dr. Finger, go ahead.
All right, thank you, Ken and Kimberly. I would like to acknowledge the Department of Education again. I think Ken and Dr. Brumley and the entire team there has done an unbelievable job in taking a complicated scenario and in a relatively short time frame, put together a document that I think can speak to everyone. There are questions about it, I understand, and we'll attempt to answer those and make them translatable and into real life. But I do think it gives a sense of the emergence of this pandemic and where we are now. So here in Louisiana, we're almost exactly 4 months to the day of our first documented COVID-19 infection back on March 9th. And I think I speak for everyone where it's been a roller coaster of emotions and things that we've had to address and deal with in both our personal and professional lives. So I'm honored to be a part of the Department of Education and Children's Hospital effort to safely return our children and all team members to school this fall. Just to sort of give you a sense of where we are in the state of Louisiana. You know, I think people have talked about a second phase of the pandemic. I don't think we ever exited the first phase. This is ongoing, and although we have lower levels of infection now than we did back in late March and early April, we certainly have hot spots in different areas and regions throughout our state. Everyone on the call knows that children are uniquely less affected by this disease than adults. But just some numbers for you to take home for the state of Louisiana. Thus far, a little bit over 4,000 children have been diagnosed with COVID-19, which is about 6% of the number of cases that have been diagnosed throughout the entire state. This matches some areas of the country with our same prevalence. And the primary reason is that children are far more likely to be completely asymptomatic or have incredibly mild symptoms that might not be picked up. What we've noticed in our experience here in Orleans Parish and the greater metropolitan area is that the vast majority of children who do have this diagnosis made, our supposition is that they have, it has been spread to them by an adult in their same household. There's no proof of that, but that seems to be the leading indicator for children who get this disease. That being said, we are still learning about this. Again, we're only 4 months into the North American experience, and all the information that we provided are going to interpret for you today is based on our knowledge that we've gained to date. As we learn more about it, and I discussed with Ken when we first spoke several months ago, was that all of this information has an expiration date, and it might be different in 1 to 2 weeks or 1 to 2 months. And our job is to help get that message to you in a real-time format. But it's still ongoing, and our goal, along with the national pediatric institutions, is to see what we can do to safely return our kids to school and make sure we can keep them and all of the team members that work to educate our children safe. Next slide, Kimberly. So again, there's a lot of minutia in the guidelines, and that's intentional. But I think if you're going to message things to your team members and your families, the number one thing we can do is if a child or team member is sick, they need to stay home. At this point in time, it's very challenging to know without testing someone whether a fever and a cough is due to COVID-19 or due to something else. And we have been very, very strong in recommending that if you're at all sick, stay home, contact your primary care provider to discuss next steps. The other thing that we'll go through when we go through the Q&A session is wearing a mask has proven to decrease transmission of this disease. We'll go through what our recommendations are for schools, but we felt it was very important to encourage mask wearing upon times of entry and exit and when you're in high thoroughfare situations in between classes. And we made a recommendation for a cutoff age for when those children should wear, what age children or what grade children should wear masks, keeping in mind that there needs to be some flexibility with how that is sort of leveraged within each school environment, and that it should not be utilized as a disciplinary tool. And finally, as you've all gone through the guidelines, the emphasis on socially distanced to the maximum extent possible is worded several times, to the maximum extent possible. I think the goal is to get 5.5 to 6 feet between children or students, excuse me. If you can only get desks 5.5 feet apart, that's to the maximal extent possible, and that's probably okay. Again, what we're doing here is risk mitigation and really trying to minimize the potential for any exposure. This is not risk elimination, and I think anyone who's on the call needs to understand that. This is not 100% foolproof or not 100% going to prevent any school-based transmission or potential transmission of COVID-19. We can't do that, but what we can do is everything possible to minimize the potential for the spread of the disease. And I think that's reasonable given the current state of affairs. Next slide. So I think Kimberly's taken some of the questions that we've gotten in a previous town hall that we did with Ken and tried to put them into slides. And at this point, I will ask you guys, feel free to sort of send questions into Kimberly, and she'll keep a compendium of them and sort of prompt me at the end of this. I think, some people have said, well, it's not specific enough, some of these guidelines. I actually think that that's okay, because as we look across the entire state, every school environment is slightly different. The physical plant, the type of students that attend that school, the volume of students and teachers, et cetera. So I think we were leaving it up to school leaders to determine best how they can operationalize these guidelines within their own school environment. And I think that's okay to do. I think being overly prescriptive doesn't leave enough leeway for school leaders like who are on the phone today to determine what's best for their own school environment. I think the mask recommendations that we came up with are at a certain grade, recommending that they wear face coverings as tolerated to the maximum extent possible. I think we deviate a little bit from the actual CDC guidelines, but as we've learned over the last 4 months, some of those guidelines we need to make into things that are truly operational. And I think keeping a mask on a really young kid might lead to more problems than it's actually worth, and might cause them to touch their face and fiddle with their mask more than we want them to do. There are some school districts from around the state who I know have made their mask recommendations to a lower age, and that is fine based on their own school environment and their interactions with their families and what they've wanted to do. So that's okay. Temperature checks. We say that those should be done once a day. We're not prescriptive that they need to be done before a child comes onto the campus, because figuring out how to operationalize that, we don't want a long line of kids standing in the August sun outside of school congregating tightly. So we determined that it's okay to just do that over the course of the morning to have temperature checks done. That's okay, and we do not believe that that will increase the risk exponentially if someone is identified to have a fever. Environmental cleaning. There's going to be another webinar that's dedicated specifically to this, town hall later on this summer. Water fountains, I think, we've made a recommendation that's outlined in the Department of Education document that those should be cleaned, as much as possible. Some schools have asked me if they should be turned off, and I've said, you can do that as long as there's another hydration supply for children and teachers. Frequently touched areas. I think, again, that's up to you to interpret that. I think a doorknob is a frequently touched area, but sort of a chair in a library that is in a corner probably doesn't need to be cleaned with the same degree of frequency that the doorknob to the entrance of the school or a hallway or a classroom needs to. Cleaning supplies, again, we're not going to be specific about that. There are lots of links to those documents, but there's nothing different than the normal cleaning supplies that need to be used, just some of the frequency that needs to be used. And I think that's included in the document as well. Next slide. Before we get to scenarios, Kimberly, can you tell me if there's any questions that you've been able to discern from the chat box, please?
Yeah, so there's a couple of questions that came in that I think will be answered by this slide, and I can circle back on them if they're not. But as far as the masks, will you please specify the grade requirement? That is indeed third grade and up?
Yeah, the current grade requirement is for grade 3 and up as tolerated. And again, so that's third grade and up as tolerated, or I think the wording we used with Ken was to the maximum extent possible. Specifically, the most important times is when children arrive to school, when they're dismissed, and any other transit time in the hallways in between classes.
Yeah, Dr. If I could add that's correct in the most recent guidance, and there was, the expectation is that all adults in the school are wearing a face covering, as well as all students grades 3 and above. There is a little flexibility in the language because we understand that there may be a medical exception and or something where there is a student who receives speech therapy, as an example, where that face covering would need to be pulled down so that the therapist could work and help that student with their speech, of course, with social distancing in place. But yes, you are correct. The current language in the guidance is the expectation for all third graders and above, all adults on campus, understanding that there may be medical exceptionalities and or instructional instances, like in the example of speech therapy, where that student may need to pull that mask down for a therapy session.
All right, thank you, Ken, for chiming in with that clarification. Why don't I go ahead and take us through some of these, I don't want to say most common scenarios, but certainly common questions that I've been asked. So if a child shows up with a fever and they have, and then they're identified to be sick at school, that first bullet point is a student or adult exposed with or without symptoms. So let's pretend that the kid is at school, has a fever and a cough. What we would recommend doing at this point is routing that through your local regional medical director and Office of Public Health, because they want to be involved and work with each individual school leader to determine if any actions need to be taken within the larger school environment that exists. I think I have worked closely with the Office of Public Health in an effort to understand their decision making, and at this point in time, they still would like to be involved with the school principals, the school leaders, and have some degree of ownership of helping the teams do effective contact tracing. It's impossible to go over every example or hypothetical situation that might happen. So I'll hesitate to say exactly what will happen because I don't know until we really start schools and see what that looks like. If a student or adult does test positive, the local Office of Public Health will coordinate directly that communication with the local school leader. And I think there's even draft letters that are ready to go out and how to communicate to parents or other team members who might have possibly been exposed. So I think there's something just showed up in my Q&A about want to be sure to ask about steps for schools to follow when a student shows up at school with any symptoms. So right now, in addition to just separating them, what we're recommending is that might be a time that you could call our hotline with a medical question, and we would be able to help route that either to someone who can handle that question in real time, or direct that child to go home and seek care with their primary care provider. Other than that, there's nothing in real time that the schools need to do with the remainder of the children in the classroom or any type of actions based on just someone who comes to school without symptoms but does not have a diagnosis of COVID-19. And I'm going to pause there. Kimberly, any other questions relating to that? I see the chat box is blowing up.
Yes. So I wouldn't say there's any questions that are coming up right now specific to the scenarios you just described, but we did get some questions around what exposure actually means, as well as if there's additional support that you can offer to teachers and adults that are educators below 3rd grade to comfort them around not wearing masks. There seemed to be some anxiety around that.
Yeah, I think there's not a lot of data on that right now, because I think we haven't exposed kids in that age group to a shared environment like we're proposing. I think as the biggest thing that those caregivers can do is wear a mask themselves. Okay, so that would be number one. Again, this is only for the younger kids. And I would say what we've seen so far, certainly our observations in the greater metropolitan area of New Orleans and with my peers in Seattle and New York, that spread from young children to adults, we have not seen as a primary vector. Rather, it's reversed, that it's adult caregivers in the home who give that disease to these younger kids. Again, it's too early to make that conclusion definitively in the course of this pandemic, but that's what we've observed here, not just in New Orleans, but my colleagues in those sort of early hotspots of Washington State, New York City.
Thanks, Liron. Additional to the scenario discussion, can you clarify to what extent people should be quarantined after a positive test is discovered?
Sure. So again, hypothetically, let's say an individual has a positive test. The road for quarantine will depend a lot on their symptomatology, and this might evolve more by the time school opens. But right now, what we're doing is quarantine is occurring for a period of somewhere between 10 days and 2 weeks. We've erred on the side of 2 weeks because that's a simple number. If someone is symptomatic, they also need to be symptom-free for a period of 72 hours. So that period of quarantine could extend longer than 14 days if someone is still symptomatic at that 2-week period.
And also to comment on our hotline, there is a capability for those who have tested positive to enroll in any at-home monitoring so that we can keep an eye on those symptoms as quarantine continues. Could you also circle back on the cleaning topic that we just covered? And there's a couple of items that have specifically come up. One is in regard to push faucets in the bathroom versus hand sanitizer. And the second one is whether AC vents in the school or in mobile vehicles should be switched out regularly to prevent the spread of circulating air.
So I'll answer the question about the bathroom faucets first. I think that's dealer's choice. I don't think one is preferable to the other. Depending on the age of the student and what type of student population you're serving, I think having both soap and water as well as hand sanitizer available in the restroom is probably appropriate. I think that was that question. So there's not one is better than the other as long as the kids actually wash their hands with one or the other. Kimberly, can you just tell me that question again about the AC units? AC units that recirculate air, no specific recommendations on anything that you need to do to change filters with any higher frequency than you normally would.
Great. Yes, the question centered around AC vents in schools and then in vehicles transporting children. So specifically a bus for special needs children, those are often air conditioned. And if there's any special modifications you can take to adjust that circulation pattern.
No special modifications are indicated. I do see another question about a mask. Does it have to be a mask or can it be a neck gaiter? Anything that covers the nose and mouth is appropriate. I think, the ones I've seen that are more comfortable, you don't have to wear a surgical mask. I think a cloth mask is fine, or anything that covers the nose and the mouth. It's important to know that it shouldn't just be covering the mouth. It needs to cover, especially in children, both the nose and the mouth.
Dr. Vinger, can face shields replace a cloth mask?
At this time, face shields are not recommended to replace a cloth mask. The mask is specifically over the mouth and prevents the smallest particles from being expectorated into the air environment. I've heard that question a lot, especially as it makes it easier specifically for teachers to communicate effectively. But at this time, that's not what the CDC recommendations are doing. And Dr. Welch from the state of Louisiana and I have discussed that at length.
What if a teacher who is masked has to visit several classrooms and then that teacher is found positive for COVID-19? How would you want to handle the next steps for classrooms that teacher was in?
Yeah, so ideally that teacher is practicing social distancing to be at more than 6 feet from her students. But again, I think that's going to be something that we're going to ask for some personal and professional responsibility. So if that's the case, then ideally, when the Office of Public Health in that school's area gets contacted, they'll be able to take that information, and I would make the determination that no other children were at risk of that exposure, because that would not meet my close contact definition.
What if the teacher is in a static class of maybe 25 children and they do test positive? How would you decide who needs to be quarantined, who needs to be tested? And what's your reasoning behind that? So
that's going to be the local Office of Public Health will help make those determinations. They will dialogue with the teacher specifically and ask very granular questions about sort of how the classroom functions, what their contact with the children is, to really get a sense of the potential risk for contagious spread within that classroom. I think there's no other way to do that other than trying to drill down into some of those finer details that you can't do without a direct conversation.
Now, circling back on temperature checks, what are your thoughts around the best way to implement those? whether a first or a second temperature should be taken on the same child, and if any special type of thermometer is necessary.
I would strongly recommend a thermometer that you don't need to touch to the child, because then it does not need to be cleaned. So any of those things that you can sort of point the infrared ones at their foreheads and get a thermometer, I'm sure everyone knows what I'm talking about. There's not a specific brand that is better than another. The times we would recommend retaking a temperature is if it's like right after a child walks in from outside and it's a very low grade fever. You might want to wait 15 minutes and retest it just to see if it was warmth from the summer heat. But otherwise, just that single temperature that's obtained sort of after school entry to the school or wherever you deem it more operationally effective for your environment is fine. There doesn't have to be a second temperature taken. But I think most people will probably wait 15 minutes and redo it, especially if it's done upon entry.
And what are your thoughts around school events involving choir and band and activities like that?
Might ask call for a favor from Ken, but my belief is that choir and band are things that will be implemented in phase 3 and are not sort of available in phase 2, which the current state is in. And once we are in phase 3, those should be able to be done, but with some degree of physical distancing. Is that correct, Ken?
Yeah, you have answered that correctly. They're in the guidelines, phase 3 for the choir and in the band. And Dr. Finger, I'd also just come back to a question you posed earlier. And one of the things in the guidelines is we do have on the very last page of our guideline documents, which I posted in the chat feature. We have a kind of a 1, 2, 3 paint by numbers about what to do when a student in school tests positive for COVID-19. That third step, and this was in consultation with the Office of Public Health, it talks in here about step 1 says that the student should not, if a student tests positive or presumptive positive, should not attend school until determined to be non-infectious by their doctor. Meaning that if I'm that student, I got off the bus, I had the temperature check, it ended up being that I was isolated and I went home and I did have a positive COVID-19, that my return to school would be determined when my doctor indicated that I was no longer infectious. And so with that, I'd lead this to you, Dr. Finger, is if maybe you could also just talk about what does it mean to be non-infectious? I know we've had that almost on every call, and you guys have answered that for folks about infectious versus non-infectious.
Well, how about I just focus specifically on infectious with relation to COVID-19?
Sure.
Although we don't know definitively, what we suspect is that people have the potential to be quote unquote infectious up to 2 days before they develop symptoms, and the highest rate chance for them being infectious are within those first 4 to 5 days after they develop symptoms. But as we also know, there's lots of people who are asymptomatic. So for them, we don't know when that infectious period, or sort of that 2 days before to 5 days after, starts and ends. So it's really challenging. But for the folks who are symptoms, what we've learned thus far is those 2 days before up to those first 4 to 5 days after they develop symptoms are the highest chances of infection.
How about logging temperature checks and documenting information like that? What Ken, and maybe this is a question for you, will schools need to keep record of that type of information over time?
I'm sorry, for temperatures? Is that what the question was?
Yes.
So I'll jump in. I think that would be a labor that does not yield a lot of results. So I don't want to, hopefully I didn't step erroneously into something that Ken thought otherwise, but I don't think that those temperatures need to be logged for documentation, or else you'll have a lot of numbers written down on a sheet for many, many weeks.
Yep, that is correct. There's nothing in guidance and requirements that would require a school system to log temperature checks.
Ken, would you also mind taking a moment to elaborate on procedures that schools need to follow for when someone is positive? Who do they report that to? How do they keep track of those cases at their school, or will that information be coming through the regional medical director?
Yeah, again, this is if in the chat feature I posted the link to the resources, but there is a 1, 2, 3 steps about what are the steps when a student in school tests positive for COVID-19. The first one is that the student goes home and does not attend school until they're determined to be non-infectious by their physician. Number 2 is the parents may be notified by the Office of Public Health if their child may have been exposed to a case of COVID-19, along with any next steps. And then we talk about if it is determined that a school was the focus of an infection of COVID-19, that the school superintendent, in consultation with the Office of Public Health, would determine if the school should remain open or close for a period of time. And we close that last statement out with a positive case of COVID-19 does not necessarily warrant classroom or school closure.
Yeah, I think that's absolutely correct, Ken. I do see a question in the chat. Should we notify parents of kids that are in the same classroom of a student who went home that a student in the classroom was sent home with COVID symptoms? I do not think that's necessary. I strongly agree with the pathway that Ken just laid out, that that notification only needs to occur in conjunction with the school leader and Office of Public Health once the diagnosis of COVID-19 is made.
Dr. Finger, will you elaborate on realistic implementations for these guidelines around students with special needs or vulnerable individuals, meaning vulnerable team members and teachers? We had a specific question come up about a hearing impaired student and whether if there's an option for, if they need to be able to, read lips. That's just a specific example.
Yeah, I think that's an example that's slightly different. Let me handle the first question, Kimberly, which is sort of children or team members with chronic medical conditions or perhaps age that might put them at a higher risk for the disease than teenagers or folks in their 20s. What we've learned thus far is that although not as uniquely affected as adults with a lot of comorbid medical conditions, we have seen some children with chronic medical conditions get uniquely affected by this disease. By and large, that number is far smaller than the adult population, but also the parents, and these are children with cancer, true chronic medical conditions, not just asthma, if that makes some degree of sense. So it's kids who have real immune systems that are compromised by a severe medical condition. The hearing impaired student is a little bit different, and I might encourage an offline discussion with a member of the Department of Education and another member of our team to discuss the specifics of what you might do in a situation like that.
Another specific question that's come up around a special needs child involves those that have to use a vent or a trach, and I assume that would also include an offline conversation to assess the individual situation.
Yeah, I think I saw a question from a nurse about PPE. I think just for those folks on the phone, what we've really encouraged for kids with who take albuterol or what's known as a breathing treatment is they use something that's called a meter dose inhaler as opposed to a nebulizer machine. I think that makes it easier, disperses particles much less. So I think that's one of the recommendations we're making. And if there's any school nurses or health workers on the phone, they'll understand what I'm talking about.
And we've had several questions come in around sports. In phase 3, will sports be allowed? And if they are, what does that look like?
Yes, we're going to have another session on that town hall later on this summer with my partner, Dr. Gonzalez, who's an orthopedic surgeon and has been leading this effort in conjunction with the LHSAA. I think there's going to be sort of sports allowed in phase 3 within sort of defined contact groups. There's a lot of discussion about what exactly that looks like right now. Am I right about that, Ken, that that's still in evolution for what that, the specifics, excuse me, of what that looked like?
Yes, the guidelines that were released said that, you know, non-contact sports could occur in phase 1 and 2. Right. Phase 3 is within defined groups and precautions in place. The contact sports could begin again with lots of conditions that must be in place for them to take place. We have leveraged the High School Athletic Association definitions, which were also, they worked with the American Pediatric Association to define those and put them into buckets. So, for instance, you know, cross country would be deemed like a non-contact sport, which would be the phase 1-2, whereas, you know, your footballs and your volleyballs or wrestling, for example, would be that contact sport in a phase 3. And correct, relative to whether or not that, you know, how those sports seasons are handled is something that the department worked closely with in the High School Athletic Association.
And the way that we handle sports will be very similar to advice for managing PE activities. Is that correct?
Yes, that is correct. Yes.
I see a question on the chat from Dr. Ellender about to the maximum extent possible has no minimum definition, and that's correct. Ken and I went over this, discussed this several times, and our concern was if we put a minimum definition, that would translate into that's acceptable when we really want people to work towards 6 feet to the maximal extent possible. So there's not a minimum definition.
And there still seems to be some confusion around how much singing is possible in phase 2 versus phase 3. I know that choir may or may not take place altogether, but what about just singing in classrooms or any type of singing?
I see that. I think the cleanup song in kindergarten and first grade is totally fine. And I think we need to balance all of these recommendations with what we're trying to do for the kids and our teachers is re-immerse them and expose them to, you know, in-person educational activities. And I think that's an important part of it. So I think that's okay.
And we're having several questions come up about different scenarios for teachers, nurses, and students that actually test positive. We will have a town hall that's specifically focused on these types of scenarios, and we can elaborate further. Seems that we're answering that kind of in different ways. So we'll follow up on that with another targeted town hall. Absolutely.
I see a question about how to effectively isolate someone who is sick. I think if you've got, you know, there's probably not, you know, 18 rooms on a campus to put one student. So I think if there's a designated nurse's office or area to put a child who's waiting to go home, I think it's okay to have another child sitting there. If they're old enough, I would encourage that that they utilize their masks or whatever face coverings they brought with them to school while they wait in there, and that they socially distance from the other children within that single room. I think that's the question that Sheremy Kurth asked.
I would also add to that, Dr. Finger, that on page 15 of our guidelines, we had a reopening checklist for facility and operation protocols. One of the items on that checklist for reopening is to identify an isolated health room or areas, and we do link to the Centers for Disease Control guidance on students who are sick, so that there's, you know, more in-depth information actually on the CDC that they can refer to for establishing those areas.
Dr. Finger, is there any real difference between protocols for adults versus children if somebody tests positive or has been exposed?
At this time, there's not a tiered response. I think if someone is a close contact or test positive, the recommendations from the CDC that we've been following are not differentiated by age. So there's not a different policy or protocol. I think, is that answering the question, Kimberly?
Yes.
Okay.
Additionally, what if, say there's a parent and a child that both test positive for COVID-19 and have constant exposure to each other? How would that look from a quarantine perspective?
What we've interpreted the guidelines, and this is myself and my infectious disease chief here, that initially we tried to really specifically isolate folks within the house from the rest of their family. But in actuality, by the time we've made the diagnosis, our suspicion is that the entire household has indeed been exposed. So I think our job is just to recommend quarantining at home. Our recommendation is, if there's the ability to separate rooms, et cetera, that they do that. But I know that's not realistic, and that's not been our experience as we've tracked patients over the last 4 months. So there's no reason to remove someone from a house or anything like that.
These next questions are centering around whether you can access this town hall, these slides, or similar information that we're discussing after this is over. And you might want to elaborate on this response, but there will be an FAQ dynamic site posted by the Department of Education, and we can share that link as well. We will also record this town hall, and it will be made available afterwards. The Department of Education is planning on posting that.
There's I see another question about what's the most likely mode of transmission, hands or mouth. It's respiratory droplets. I think we're making all the recommendations about cleaning surfaces at this point in time because so much is unknown. But by and large, the cases that we've seen in children have been due to close contacts and not picked up off something in the environment. I see a question about if a sibling is test positive, do all the siblings stay home or can they go to school? So they would be, by definition, a close contact because they live in the same household, and they will fall under the home quarantine for that defined period of time.
Dr. Finger, what do you think the return to school versus return to work process will look like? Is it advised that students or adults have 2 negative tests, or they're just symptom-free? What are your thoughts?
No, I think right now we're going to follow sort of the CDC guidelines, which have changed a little bit over time. Right, and I think early on, so right now we're not necessarily going to require a negative test, although I know that the CDC is in the process of putting out some new recommendations that might come out even this week if they weren't released this morning. So I'll have to pause on that and say I want to wait to see what their recommendations are going to be.
As far as going back to the school environment, being on campus every day, can students share computer labs and tools and certain skill labs, or even share instruments? What does wiping that down look like?
I would say yes to sharing tools and computer labs. I think probably sharing a clarinet might be, we wouldn't want them to use the same mouthpiece, but sharing like drumsticks and things like that would certainly be okay in my mind.
Can you elaborate on the purpose behind antibody testing and whether that would be appropriate for schools?
Sure. Antibody testing tells us one thing and one thing only: whether the individual who was tested has antibodies to COVID-19, which means that they were exposed to COVID-19 likely more than 2 to 4 weeks before those antibodies are obtained. It doesn't tell us anything about their protection from COVID-19 disease moving forward. We don't know enough about whether those antibodies confer immunity at this point in time, although there's a lot of work going on right now to make that determination. So I don't think it's recommended necessarily that schools utilize antibody testing for any sort of data collection at this point.
And would you recommend a school at any point testing their entire student body or doing batch testing for any reason? Batch
testing is different from testing the entire school. So I think testing the entire school at this point in time, we're not recommending, because that gives you a snapshot of what you're doing. And I think having the resources to do that, we have to balance with the bang for the buck that you'll get from that. I think we'll get much more bang for the buck and minimization of the spread of disease by focusing on all the other items that are mentioned within the document for physical distancing, et cetera. Using lockers for students is fine. So as long as we're promoting good hand hygiene, there's fine. Question about, can you get COVID a second time? It's really too early to know that. We have seen that some people, a small portion of the population, test positive for longer than 2 to 3 weeks after they've had their initial positive test. They're almost all, some of them have been completely asymptomatic and some of them have nagging symptoms. I don't think they have gotten the disease a second time. I think it's just lingering longer than what's within the normal bell curve. So to answer the question shortly, we don't know if you can get COVID a second time yet. I do not believe lockers need to be deep cleaned daily, just the exterior surfaces that are touched wipe down.
We also had a question about how the American Academy of Pediatrics does recommend elementary school kids return to campus. Does the DOE and Children's recommend that as well?
Absolutely. AAP and all the pediatrician leaders across the country have recommended doing everything we can, because I think we all know about the scholastic achievement that's obtained, but I think the mental growth and being around friends and classmates and teachers is something that is challenging to replicate in the distance learning environment.
And we seem to have had several last-minute questions come up around cleaning again. Would you recommend any intense cleaning protocols after someone is identified as positive, i.e. fogging or really intense cleaning agents in classrooms?
No.
Okay. What about deep cleaning lockers and things like that, sports bags?
I think those doorknobs and light switches might be higher touch. I think just wiping them down, but deep cleaning is probably not a feasible, and I think there's not a lot of bang for that buck either.
Okay. Well, we're getting down to the last 5 minutes of the town hall. It seems like there were various versions of scenario questions around someone that could potentially be positive. We'll make sure to elaborate on that in our future town halls. But are there any last minute questions with topics that we've not touched on so far? Okay.
I wanted to thank everyone for being so open to asking questions. I hope I was able to give you a sense of, I don't want to say normalcy, but what the new normal is going to look like. And to all the educators who are on this call, I want to thank you, not just professionally, but personally. I have 3 girls who are in the Orleans Parish Public School System. I know they can't wait to get back to their teachers. So I appreciate everything that you're doing in an effort to get our children back in schools. What I see a ton of questions coming in. I know that Kimberly will be able to document those, and we'll include those answers in the fact sheet that we put together in conjunction with the Department of Education.
We'll also incorporate answers to several of these questions in our upcoming town halls that will be specifically targeted at certain topics. And again, I know I mentioned this beforehand, but we'll expand on janitorial tips, nurses and teachers can expect, how to handle different scenarios, and we'll even include how support staff across the school can be informed and supported during this time as well. Please don't hesitate to reach out.
One more question about temperature checking. There's not a specific time of day, but try and do that in the first couple of periods as that you sort of open classroom. If you're not doing it at the gate or the front door, I wouldn't try and do the temperature check at 2:30 in the afternoon. So again, we're not going to be prescriptive about that, but just have a process that you can operationalize across the greater school environment in order to take the temperature throughout the early morning period.
Thank you everyone for your time today, and thank you, Dr. Finger.
Okay, thank you all. Be safe out there.
Take care. We'll see you in 2 weeks.